Typically, we have a patient, for example, a corneal opacity with cataract. Earlier, we used to go ahead with the triple procedure, and particularly with the PK, ECC plus IOL. But in patients who are one-eyed and elderly with very poor dexterity and very poor compliance, and as we all know that there is a chance always of a poor graft survival, it's always better to take out the cataract and see how much actually the ambulatory vision the patient develops and how much is able to do the activities of daily living. But in certain situations like this, yes, we need to go ahead with the replacement of the cornea as well as the cataract surgery. Now there's a lot of capsule staining actually with a lot of agents has come, but the best sustained is the trypan blue. Typically stains the white cataract, and if there is a poor red reflex associated with asteroid hyalosis or darkness in nucleus, it's very easy to visualize them in situations like where there is a dense corneal scarring as well as corneal edema. And in patients with nebulomacular corneal opacity as well as cataract, the difficult phacoemulsification is converted into a better situation with the help of trypan blue. And I would suggest that you stain more and more. This was a one-eyed patient actually, and with a complete half cornea covered with a nebulomacular corneal opacity with vascularized cornea. Since there is more than 2-quadrant deep vascularization, it's better that we go ahead with the only cataract surgery. And as we see that there is a lot of clearing of the one side of the cornea, so it's always easier to operate in that situation rather than focusing on this segment. Only thing is we need to take care that we need to stain these capsules with trypan blue in undiluted form. Don't dilute it. So allow it to stain for more than 6 seconds to 30 seconds almost, so that you see the capsule nicely, and then you can go ahead with the cataract surgery in a very routine manner. And as you can see that the rhexis can be easily achieved in such cases because the contrast which is given by the trypan blue. So simple agents such as trypan blue helps a lot in maintaining the visualization of the capsule and helps us to retain it. And nowadays we can even use endoilluminators in patients with dense corneal opacities, but nothing like trypan blue. And these are the patients actually who are going to improve over a period of time. And this was a case of vascularized corneal opacity which was post-herpetic, and even after cataract surgery we kept the patient on systemic acyclovir for more than almost 5-6 years. So such one-eyed patients who delay their cataract to such an extent that they're very quite apprehensive, they don't want to go ahead with the cataract surgery, and this is the best option. And it's better always to be done by an experienced surgeon because these are one-eyed patients. And once you achieve a rhexis, I don't think that will be an issue. You can directly go ahead and with the routine phacoemulsification procedure. Make sure that you do your nucleotomy and chop and everything actually in the clear corneal area, whichever area we are able to visualize. This is another case. I'll just skip this. This is similar. You can see one-eyed patient with severe vascularization and with the corneal opacity. And such cases actually need to be iris hooks needs to be used, and then go ahead with the trypan blue staining and then with the capsule oil. This was during my senior residency time, and it was a patient of one-eyed with scleromyelitis perforans. Hardly there was anything left over actually in the cornea. You can see there is 4 mm cornea which is done in RP center. And such is an extreme case that you find some cornea wherever it's possible, and then go inside and try to stain the capsule and then go ahead, because the patient, such are the patients actually who have a limited longevity, because once there's a scleral involvement to such an extent, they have other mitral patient died because of 5-degree agitation after 6 years of follow-up. So, but still we could be able to give him a very good visual acuity actually with the basic staining techniques and with the basic phacoemulsification procedures. Wherever there is a clear of cornea, try to involve that in your procedure and try to coat the endothelium with viscoat as much as possible, and try to be slow and gentle during the phacoemulsification, and try to keep your probe away from the cornea as much as possible. So it gives you a good CCC. Apart from that, a stained peripheral rim. Apart from that, it also gives us sustained feathery cortical fibers which are visualized better. And it can be used both as a primary therapeutic options, in which, as I told, where no penetrating keratoplasty is not possible, or an interim procedure where the patient is waiting for a PK. And there are lots of now techniques which have come up, like D-LAC with phaco and D-SAC with phaco, which we are doing routinely. And there are a lot of papers on that deep lamellar keratoplasty with phacoemulsification is a safe procedure. And even femtosecond laser assisted keratoplasty is done to aid the visualization before the cataract surgery, and it can be done in a similar setting. And temporary graft for closed system cataract surgery can also be used. But this is what is routinely followed, a single step procedure where both lamellar keratoplasty and as well as cataract surgery is done. But only thing is, it needs to be done by an experienced surgeon who is well versed with both the lamellar keratoplasty as well as the cataract surgery. Like this was a case where we went into a manual deep lamellar keratoplasty because the corneal opacity was quite dense, and we could go up till the Descemet membrane. Since Descemet membrane was also involved, you cannot go ahead with the big bubble technique. And so once you do a trephination, actually you go for a partial trephination, then you achieve a big bubble. Then with the big bubble, after that, actually you remove the anterior part, and the enhanced visualization which you achieve with these things, you can go to the just keep on irrigating the Descemet's membrane or the posterior stroma, which is there with saline, and that will enhance your visualization for the phacoemulsification. So deep lamellar dissection of the cornea should be achieved first either with the viscoelastic or with the simple big bubble technique. And the only problem is, actually you have a collapsed anterior chamber every time, because the Descemet membrane being very thin, you have all the propensity of damaging it. So if people are not confident, better to go ahead as a two-step procedure, because these are young patients and usually they don't have cataract unless there is a vascularized corneal opacity with Descemet's involvement. So at the end of the surgery, once the phaco is done, we put a full thickness donor button into the recipient bed, and its Descemet's membrane was. Really, this is the one technique which is helpful for the patients with dense corneal opacity. The IOL selections introduces this. Very important that these are the patients. Standard monofocal is the best. Don't go to any other type of lenses. Remember that after DSAC, actually there will be a hyperopic shift because these are the patients. Selecting the IOL power for few of these patients, you should aim for minus 1.25 diopter of myopia to compensate. This is very important that we forget and finally land up in a refractive surprise. And to get a clear view, as I told you, simple, you can scrape off the epithelium in the center of the cornea, and you can stain with the trypan blue as the routine DSAC, which has become very common, and then making it easier during the Descemet rhexis. The size of the capsular rhexis should be smaller than the diameter of the IOL, so that you don't damage the graft in the during the process. So this lens dislocation actually into the anterior chamber should not happen. The rhexis should be very small. Actually, this is one thing which you need to maintain. And large optic is very important, and try to almost try to use myotics after implanting the IOL, because again there's a risk of graft dislocation, as this happened in this case, and then we could reattach with rebubbling. So to summarize, in one-eyed patient, if you have a covascularized cornea, go ahead with the trypan blue assisted phaco with optical iridectomy or without. If there is anterior involvement of the posterior stroma as well as Descemet's membrane, if there is no involvement of any of these structures in the posterior part, go for deep LK, that is lamellar keratoplasty with trypan blue assisted phaco. Endo-illuminator assisted phaco or Lumera 700 assisted stereocoaxial illumination also helps in lots of cases if facilities are available. In very dense corneal opacity, you are not able to handle it, nothing is being visible involving the posterior stroma and Descemet's, PK with cataract still has a role to play in such case. Thank you very much for your patience.